Coronary artery bifurcation disease remains a real treatment challenge. I'm with Dr. Martin Leon, the principal investigator of the Tryton Bifurcation Trial, a randomized comparison of a provisional 1 stent versus a dedicated 2 stent strategy for true bifurcation coronary lesions. We have tried a number of things for these patients. Tell me about the Tryton side branch stent.
Well, the Tryton side branch stent is a dedicated bifurcation stent. It's a stent that spans the side branch into the main vessel. Some people call it a semi-culotte stent design. It is a bare metal cobalt alloy stent that is meant to protect the side branch and then to integrate with the main vessel where a drug-eluting stent is placed in the main vessel. So it's an interesting device that's relatively easy to use, that has been available in Europe for now many years with over 1,000 patients being treated, that we felt and feel may have some contribution for treating the more complex bifurcation lesions.
In the late breaker that you're presenting here at TCT, tell me about the patients first.
Well, the patients were meant to be true bifurcations. We use that term to mean that both the side branch and the main vessel have obstructions beyond a certain degree. And fortunately, we were successful in being able to enroll those patients. By visual assessment, 99% of the patients fulfill that categorization, and by core lab assessment, 88%, which is very high. These are patients that were symptomatic and who had a significant coronary disease, 75% of which were in the LAD diagonal. So it's a complex group of patients with true bifurcation disease.
So what results are you presenting here at TCT?
So we're going to present the primary results of this pivotal clinical trial. It's the largest study that's ever been done, randomized trial in bifurcations, and it's the first time that a dedicated bifurcation stent has been studied in a randomized trial. So it's 704 patients that were equally randomized to the two groups, and we're going to present the clinical primary endpoint and the powered secondary angiographic follow-up endpoint.
And what did you find?
The primary endpoint is a composite, something we use commonly in interventional cardiology, called target vessel failure, which is a combination of death, target vessel myocardial infarction, and repeat revascularization. And it was meant to be a non-inferiority trial design. What we learned, interestingly, was that the study did not fulfill the non-inferiority criteria, which is to say that Tryton was not non-inferior to the conventional accepted 1 stent strategy. Now that was driven, cardiac death was 0 in both groups. It was driven by a relatively high frequency of small periprocedural myocardial infarctions.
So CKMB elevations?
CKMB elevations, yes, the bane of interventional cardiology.
So you also did a secondary analysis, right, or a
Yes.
post-hoc analysis?
It's not post-hoc, it was pre-specified. It was a powered secondary analysis looking at the side branch angiographically in a large subset of patients, 326 that had angiographic follow-up. And we learned that the Tryton, as we had expected, would provide better results from the standpoint of angiographic patency in the side branch. So it fulfilled the superiority secondary analysis with an almost 10% reduction in percent diameter stenosis with the Tryton versus the conventional strategy.
So where is the Tryton side branch stent going from here?
It's a great question. I can't give you a final answer on that. I mentioned that we fulfill the mandate to enroll true bifurcation lesions, but the purpose of this stent is to treat more complex and larger bifurcations. And when we actually looked at the patients that were enrolled in the study, only 41% had side branches that were 2.25 millimeters or larger, where the entry criteria was 2.5 millimeters or larger. If we only look at that subgroup, the Tryton stent, in fact, outperformed our expectations and was significantly better than the provisional strategy. So our take of the study is that the primary clinical endpoint was driven by a higher frequency of small periprocedural MIs, and had we enrolled our intended population of larger side branches, we think we may have achieved the intended result.
So what does it tell you about trying to get the right patients?
Oh, it's so difficult.
Exactly.
We spent almost 2 years in 67 sites. This is a worldwide study involving 10 countries just to enroll the 704 patients. So it's very difficult to enroll an intended population. But some of these post-hoc secondary analyses are extremely meaningful, and I think that we'll come away feeling that the conventional strategy in smaller side branches, even if they have blockages, can be treated very acceptably with a provisional stent strategy. And there may be roles for the dedicated bifurcation stents like Tryton in the more complex, larger bifurcation segments, which comprise anywhere from, we think, about a third of all bifurcation lesions.
You had a slide on the deployment sequence. If I could just finalize on that one.
Sure.
How is this used? What's the process for this particular stent?
It's fairly straightforward. You put guide wires both in the main vessel and in the side branch. Then you prepare the side branch in the main vessel using balloons to pre-dilate the blockage. Then you implant the Tryton stent, which is a very interesting design that allows you to place a transition zone over the carina or the ostium of the side branch. And then it extends from the side branch to the main vessel. And then you, through the main vessel guide wire that is now through the Tryton main vessel segment, you implant a conventional drug-eluting stent and then finish with what's called high-pressure kissing balloon inflations.
So if you want to find out more about this particular trial, the Tryton Bifurcation Trial, please see Cardiosource World News. And for all of the papers from Jack, as we're doing interviews here at TCT, please also go to cswn.org for Cardiosource World News. I'm Rick McGuire.